Welcome to this Step 3 review on common sports injuries. This video is brought to you by Roadmap to Residency. Today we are not going to reteach every ligament and tendon. Instead, we are going to show you how the sports injury question stems are built and how to attack them, covering ankle sprains and the Ottawa Ankle Rules, knee injuries like the anterior cruciate ligament and meniscus, rotator cuff injuries of the shoulder, and return to play decisions. Make sure you are also working through your question bank and the musculoskeletal chapters of a solid review resource alongside this video, because these patterns are best learned by doing many practice questions. Let us get started. Here is what we are going to cover today. First, we will attack ankle sprain stems using the Ottawa Ankle Rules to decide exactly who needs an image and who does not. Second, we will learn the knee and shoulder patterns, such as the pivoting injury of the anterior cruciate ligament and the gradual overhead pain of a rotator cuff tear that point you to the next best step. Third, we will make clean return to play decisions the way the test writers reward. Along the way, we will walk through 3 practice questions together and explain exactly why each answer choice is right or wrong. This video assumes you have baseline knowledge from your review resources. We are here to sharpen how you take the test. Our first strategy is to read for the next best step. Start with the last line of the question. That sentence tells you what is actually being asked, whether it is the next best step, the most appropriate test, or the best management. Once you know the question, go back and read the stem with that goal in mind, and you will stop drowning in detail. Then anchor on the mechanism, because how the injury happened is the single biggest clue in a sports stem. A planting pivot with a pop points to the anterior cruciate ligament. A fall on an outstretched arm points to the shoulder. An inward rolling ankle points to the lateral ligaments. Anchor on the mechanism, and the likely diagnosis often appears before you even read the options. Train yourself to notice it every single time. Strategy 2 is to let the decision rules do the work. First, know the named rules cold. Sports injury stems are built around validated tools, and the Ottawa Ankle Rules are the classic example. When a stem hands you bony tenderness at specific landmarks, or the inability to bear weight, it is telling you exactly which rule to apply, so learn the trigger words and skip straight to the answer. Second, examine before you image. For most joints, a focused physical test comes before imaging. Think of the anterior drawer and the Lachman for the knee, or the empty can and the drop arm for the shoulder. When 2 answers are both reasonable, the better answer is often the bedside maneuver that costs nothing and changes what you do next. Strategy 3 is choosing the right imaging study, which sports injury questions test constantly. First, start with the plain film. When the stem points to a possible fracture, plain radiographs are almost always the first image. If the Ottawa Ankle Rules are met, plain films of the ankle or foot are the next best step, not advanced cross-sectional imaging. Second, reserve advanced imaging for soft tissue. Magnetic resonance imaging is the test for ligament, meniscus, and rotator cuff tears, but it is rarely the first step. It earns its place when the diagnosis is unclear, when surgery is being considered, or when a plain film is normal but the exam still worries you. Third, beware the tempting overkill answer. The test writers love to plant an immediate magnetic resonance imaging or a rush to surgery for a problem that just needs supportive care. Doing too much is wrong just as often as doing too little, so choose proportionate care. Let us work through our first practice question, and this one is built around the Ottawa Ankle Rules. A 22-year-old recreational soccer player rolls the ankle inward during a game and comes to your clinic the same day. There is swelling and tenderness over the outside of the ankle. Read the exam carefully, because it tells you there is no bony tenderness at the back edge or tip of either ankle bone. No tenderness at the base of the 5th foot bone or the navicular, and that the patient could take 4 steps right after the injury and can walk into your office now. The question asks for the most appropriate next step. Those exam details were handed to you on purpose. Read the 4 options and pick your answer, then we will walk through the reasoning on the next slide. Let us break this down. First, spot the pattern. This is a classic lateral ankle sprain from an inward rolling mechanism, with swelling and tenderness over the outside of the ankle. The stem carefully tells you there is no bony tenderness at the key landmarks and that the patient could bear weight both right after the injury and now. Next, apply the rule. Under the Ottawa Ankle Rules, an image is needed only when there is bony tenderness at those specific points or an inability to bear weight for 4 steps. This patient meets none of the criteria, so radiographs are not indicated, and the right answer is rest, ice, compression, elevation, and early mobilization. Finally, eliminate the wrong answers. Plain radiographs are wrong because the criteria are not met. Magnetic resonance imaging is the overkill trap for a routine sprain. Surgical referral is far too aggressive for a first uncomplicated sprain. The correct answer is supportive care with early mobilization. Notice how knowing the rule cold pointed you straight to it. Here is our second practice question, and this one is all about the knee. A 19-year-old basketball player plants a foot and pivots to change direction, feels a pop in the knee, and has immediate swelling within a couple of hours. On exam, the knee is swollen, and the anterior drawer and Lachman maneuvers show increased forward movement of the lower leg compared with the other side. Plain radiographs show no fracture. The question asks for the most appropriate next step. The key here is to read the mechanism and the special tests, recognize the likely diagnosis, and then choose the study that actually confirms a soft tissue injury. Pick your answer, and we will reason through it on the next slide. Let us work through this answer. First, read the mechanism. A pivoting injury, an audible pop, rapid swelling from bleeding into the joint, and a positive Lachman and anterior drawer are the textbook picture of an anterior cruciate ligament tear. The stem hands you each of these clues, and remember that a meniscus tear is on the differential and the two often occur together. Now, why does the scan win here? The plain film is already normal, so the next step to confirm the soft tissue injury and check the meniscus is magnetic resonance imaging. This is exactly the setting where advanced imaging is appropriate. Repeat films add nothing. Returning to play this week risks further damage, and casting the leg is not the standard care. The correct answer is magnetic resonance imaging of the knee. Let us talk about pacing through sports injury blocks, because these stems have a particular rhythm. They are often long, with a detailed mechanism and a whole string of exam findings, but the answer usually turns on just one or two key clues. You have a little over 1 minute per question on average, so first, know the clock and the pace. Train yourself to jump to the last line, find the mechanism, and commit rather than rereading every sentence. Second, learn to flag, move on, and bank time. If a knee or shoulder stem has stalled you for more than about 90 seconds, lock in your best guess, flag it for review, and move forward. Because letting one long vignette swallow the time of 3 other questions is how blocks go unfinished. Bank the spare seconds you save on the quick pattern recognition questions, so you have room for the ones that truly require thought. Smart pacing protects every point you have earned. Here is our third practice question, and it is all about the shoulder. A 50-year-old recreational tennis player comes to the clinic with several weeks of shoulder pain that is worse with overhead reaching and at night, and there was no single injury. On exam, there is weakness and pain when the arm is raised against resistance, and the arm drifts down when the examiner lets go of it at shoulder height. There is no deformity, and plain radiographs are normal. The question asks for the most appropriate next step. Notice the gradual pain, the night pain, and those special tests. And be careful not to get pulled toward an answer that does too much or too little. Choose your answer, and we will reason through every option on the next slide. Let us break down this answer. First, read the special tests. Gradual overhead and nighttime shoulder pain with no single injury, weakness against resistance, and a positive drop arm sign, where the arm drifts down when released, all point straight to a rotator cuff tear. The plain film is already normal, so magnetic resonance imaging is the appropriate study to confirm the tear and guide management. That is the correct answer. Now the key distinction between the wrong choices. Reassurance with no workup ignores a real structural injury with weakness on exam. Immediate surgical referral for a shoulder replacement is far too aggressive and is not even the surgery for a cuff tear. Computed tomography is better for bone than for the soft tissue of the cuff, so it is the wrong imaging choice here. Every distractor does too much or the wrong thing. The correct answer is magnetic resonance imaging of the shoulder. Here is a high-yield pearl that shows up again and again in sports injury questions, and it is how to handle return-to-play decisions. These stems reward the safe, conservative answer. Before an athlete goes back, they should be nearly pain-free, have full or near-full range of motion and strength, and be able to perform their sport-specific tasks. If the stem is still describing swelling, weakness, or a positive special test, the answer is almost never to clear that athlete to play. When the choices range from an immediate return to a gradual supervised program, the test writers reward the stepwise progression that protects the athlete from re-injury. Be suspicious of any option that rushes a symptomatic athlete back onto the field. On these questions, the cautious answer that prioritizes healing is usually the correct one. That wraps up our review of common sports injuries for Step 3. Remember the core ideas we covered today. Read for the next best step and anchor on the mechanism of injury. Let the decision rules do the work and use the Ottawa Ankle Rules to decide who needs an image. Start imaging with a plain film and reserve magnetic resonance imaging for soft tissue questions about the ligament, the meniscus, and the rotator cuff. And make cautious, stepwise return to play decisions that protect the athlete from re-injury. The best way to lock all of this in is to drill musculoskeletal questions in your question bank under timed conditions and read every explanation, even on the ones you got right. Visit roadmaptoresidency.com for expert tutors and residency advisors who can help you build a personalized study plan. If you found this video helpful, please like and subscribe so you do not miss our next board review session. Good luck on your exam, and we will see you in the next video.